Head-to-toe physical exam on my patient. There is a sequence on how to go about this. First, you want to collect a health history, complete or limited as the visit warrants, and while doing this, note the person's general appearance. They appear that their stated age, level of consciousness, skin color, nutritional status, posture, position of comfortable erect, obvious physical deformities such as mobility, gait, use of assistive devices, range of motion in joints, no involuntary movement, able to rise from a seated position easily. Note their facial expression, mood, and affect, speech such as articulation, pattern, content appropriate, native language, hearing, and personal hygiene. Everything about this patient is normal and appropriate. So I had my patient stand on a scale. He weighs 155 pounds and is 5'8". We will measure the waist circumference using a measuring tape. Next, we will compute the body mass index, which is on page 131 if you have the same textbook. By taking the weight and dividing it by the height in inches squared, we can find the BMI and then multiply that by 703. And my patient's BMI is 23.6. Next, you would want to test the vision using the Snellen eye chart. We don't have that here, but the patient stated he went for a checkup last year and has 20/20 vision. For this next portion, you would ask the patient to empty their bladder, to disrobe, except for the underpants, and you want to put on a gown, which you would do in the clinical setting, but not here. The person sits with his legs dangling off the side of the bed or a table, and you stand in front of the person. Starting with the skin, we examine both the hands and inspect the nails, check for any discolorations, trauma, and check capillary refill. For the remainder of the examination, examine the skin with the corresponding regional examinations, and also check your vital signs. I just went over his skin, capillary refill, everything looks normal. We're going to move on to the head and face. We're going to inspect and palpate the scalp, hair, and cranium. His hair is evenly distributed. I'm going to check for any bumps, lesions of any sort, and everything seems to feel normal. We're going to assess the cranial nerve 7, which is for expression and symmetry. So we're going to ask the patient to smile, frown, close your eyes tightly, raise your eyebrows, and everything seems to be intact. Now I'm going to palpate the temporal artery, and then the temporomandibular joint. Open your mouth and close your mouth. All right, you can feel the muscles. Palpate the maxillary sinuses and the frontal sinuses. Any tenderness?
No.
Now we're going to test the visual fields by confrontation, which is cranial nerve 2, by assessing their peripheral vision. So look straight forward, and let me know when you can see this, my finger in your peripheral view.
I see now.
Okay. We do the same thing on the other side. Let me know when you can see my finger.
See now.
I'm going to test the extraocular muscles. Corneal light reflex by shining a light towards the eyes, and the light should be reflected at exactly the same spot in the two corneas. And they are. I'm going to do the 6 cardinal positions of gaze, which test the cranial nerves 3, 4, and 6. I'm going to start in the center. Can you see this?
Yep. 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 Yes. Yes. Yes.
Okay. We're going to inspect the external eye structures, inspect the conjunctiva, sclera, corneas, the irides, which is plural for iris, test the pupil, the size, response to the light, and accommodation. Look straight ahead, or look my ear or over my shoulder. And when I shine the light, his pupils do constrict, reactive to light, and they're equal and round. For the next part, you would want to darken the room, and as shown in my prior head, ears, eyes, nose, throat video, you would use an ophthalmoscope, which I was not able to obtain for this video, to inspect the ocular fundus for the red reflex, disc, vessels, and retinal background.
Now we're going to test for vision. I have pulled up a Snellen chart. It's not a poster or anything, but I'm going to have the patient stand 10 feet away instead of 20 feet away. Now I want you to read the first line for me.
CS.
Okay, and now the second line.
DVOH.
Okay, now the third line.
O H D C K.
Okay, and next.
The fourth, H Z C K O.
Okay, fifth line.
N C K H D.
Okay, sixth line.
D H O S Z.
Okay, seventh line.
Ooh. V R. I think that's an N. D and O.
Okay, eighth line.
Oh boy. C Z. I don't. H K. And I think that's an S.
Okay, and now the last line.
Oh my god. O B Z S K.
Mm-hmm. Now, that last line means if you're able to read all the letters up until that line, that means you have 20/20 vision.
Now we're going to move on to the ears. I'm going to inspect the external ear, the position, the alignment, skin condition, and auditory meatus. Everything seems intact. There are no lesions. There's no swelling. His hearing is intact because he was able to do everything I was saying. Any tenderness?
Yeah.
What about on this side?
No.
What about when I press down on your tragus? All right. I was able to obtain an otoscope, but due to some technical malfunctions, the battery life has expired. But I'm going to still demonstrate how to use it and do my best. Using the otoscope, we're going to inspect the canal, then the tympanic membrane for color, position, landmarks, and integrity. In the adult, we're going to hold the pinna with our right hand. If you're on the left side, you're going to hold it with your right hand, pull it up and back. And with a pediatric patient, you would hold it down and back. The normal eardrum is shiny and translucent with a pearl gray color. And when looking in the patient's right ear, the light reflex will be seen at the 5 o'clock, and in the left ear, it will be seen at the 7 o'clock. And sections of the malleus are visible through the translucent drum also. And then to test hearing, we're going to use the whispered voice test, but I'm going to demonstrate this first. Normally, you would turn the light on, and you have a disposable tip that you would use for patients. And when you go through the canal, you want to go in real slow, not to puncture or anything through the canal. And usually you would be able to see the tympanic membrane, like I had just said, and then you would do the same thing on the other side. I'm going to go behind him and I'm going to do the whispered voice test. Repeat what I say.
1, 2, 4.
Now we're going to move on to the nose. First, inspect the external nose. Note the symmetry and any lesions. Inspect the facial symmetry, which is cranial nerve 7, which we just did a few minutes ago. Test the patency of each nostril, and if you have a speculum, which we don't, we would find that in a clinic. Inspect the nares and note the nasal mucosa, septum, and turbinates. So everything, any tenderness, any pain. Okay. Everything's intact. Now with the light, we're going to inspect the mouth. We're going to assess the buccal mucosa, the teeth, gums, tongue, floor of the mouth, palate, and uvula. Open your mouth. Move your tongue up. All right, there are no lesions. His teeth look healthy. There's no bleeding, no swelling of any sort. Okay. Normally, if their tonsils are present, you would grade them. I don't have a tongue blade, but I'm gonna have to use a butter knife again and use this to assess his uvula. And as the person phonates the ah and tests the gag reflex, this will be assessing the cranial nerves 9 and 10. Put your tongue out. Say ah. Louder. Ah. All right. And the uvula comes down like it's supposed to. Also ask the person to stick out their tongue. This assesses cranial nerve 12. And with a gloved hand, you would bimanually palpate the mouth if indicated. I don't have a gloved mouth, but basically what you would do is take it like this and feel for any lumps or masses of any sort in the cheek. Now I'm going to inspect the neck for symmetry, lumps, and pulsations. We're going to palpate the cervical lymph node. Maybe around here. Sometimes you have to go a little bit deeper. And sometimes when the patient is sick, they'll be a little bit more inflamed and easier to feel. You can feel his right there. You can inspect and palpate the carotid pulse. Go this way. And you never want to do both of them at the same time because it would obstruct blood flow to the head. Okay. Next, we're going to test the range of motion and the muscle strength against my resistance. I'm going to put my hand on your face and you're going to push against it. Push against it as hard as you can. Okay. I'm going to do the other side. Okay. Next, I'm going to do the shoulder shrug test, which is going to be cranial nerve 11. I'm going to put resistance on his shoulders and he's going to push against it. Okay, back down. All right, one more time. All right. Now I'm going to step behind the patient and feel for the thyroid gland. In some patients, it's a little bit deeper, especially if they're obese. And I can feel his on both sides. And then normally while you're back here for this next part, you would go ahead and open the back of the gown and inspect the thorax. Now I'm going to inspect the thorax on the posterior side, the configuration of the thorax, the skin characteristics and symmetry of the shoulders and the muscles. We're going to palpate the symmetric expansion. So you would hold your thumb and your fingers out like this, and every time they breathe, the lungs should expand equal bilaterally. Take a deep breath in and back out. All right. I'm going to lift his shirt up to inspect his the back of his chest right quick. Skin looks normal, everything's intact, there's no swelling, any tenderness, any problems.
No.
All right, and I'm palpating the length of the spinal process. I'm going to percuss over the lung fields. And you always want to go bilaterally. When you do one side, you want to compare it to the other side. Also percuss the diaphragmatic excursion, noting the tenderness. Any tenderness or pain?
No. No.
Okay, now I'm going to auscultate breath sounds, comparing each side in the upper and lower lung fields, and note any adventitious lung sounds. Take a deep breath in and out. All right, and everything sounds normal. Now we're going to inspect the anterior chest. Prior to starting the video, I went ahead and lifted his shirt and inspected it. Everything is normal. There are no lesions, no tenderness, no swelling. I'm going to palpate for tactile phlebitis, lumps, or tenderness. And just ask the patient to keep breathing normally. Okay. Now we're going to grab my stethoscope. We're going to auscultate for breath sounds, and you want to compare each side in the upper and lateral fields. Deep breath in. All right, and everything seems to be normal. Now to assess the heart, I'm going to ask the patient to lean forward and exhale briefly. I'm going to auscultate the cardiac base for any murmurs. All right, so lean forward. Exhale. One more time. And there are no murmurs, everything is regular. Now I'm gonna assess the upper extremities. We're gonna test the range of motion and the muscle strength. We're gonna start with the hands first. Now the wrists. All sorts of motions. Now you're gonna get on a flat surface. You're gonna have to get down. Do your hands. Okay, and now with the other hand. Okay, yes, full range of motion. Now we're going to get up, we have to stand up. We're going to do the shoulders. Go up and go as far back as you can. So yes, full range of motion there. We're going to go up like this and then come like this. Okay, and you can take a seat again. I'm going to palpate the epitrochlear nodes. I'm going to do so on the other side as well. And now I'm going to palpate the radial pulse. And compare it to the other side. And now I'm going to do the brachial pulse. Relax. Sometimes you have to press a little bit deeper to find the brachial pulse. Okay. Then you're going to test just kind of with the back of your hand, feel the temperature. Or it's dry and warm. Then you want to test the capillary refill. Should be less than 3, and do it on both sides. Okay. And also you would inspect the male's breasts. He doesn't feel uncomfortable, he feels a little bit uncomfortable taking his shirt off, but you would normally help the patient lay supine or at a 30-degree angle. You would inspect and palpate the anterior chest wall, supporting each arm, and palpate the axilla and the regional nodes. Now we're going to assess the neck vessels. We're going to inspect each side of the neck for a jugular venous pulse, turning the person's head slightly to the other side. So if we're going to assess the patient's left side, we're going to ask them to turn to the right side. You see it coming down right there. And like the carotid pulse, you only want to do one side at a time to prevent obstruction of blood flow to the head. Okay, now face to your left. All right. Now we're going to assess the heart. He doesn't feel comfortable taking his shirt off, but you would inspect the precordium for any pulsations or heave. Palpate for the apical pulse, and you're going to find that on the left mid-clavicular line. You want to try to feel for that first. and then to palpate the precordium for any abnormal thrill, and then auscultate the apical rate and rhythm and make sure everything is regular. So I can hear it very well, and the rate and rhythm are both normal. Next, you would auscultate with the diaphragm of the stethoscope, which is the bigger portion of the stethoscope, to study the heart sounds inching from the apex up to the base, or vice versa. And then auscultate the heart sounds with the bell of the stethoscope, which is the smaller side, again inching through all locations. And then turn the person over to the left side while again auscultating the apex with the bell. Turn to your left side slightly. Left side. Just a little. There are no irregular sounds such as bruits or murmurs or anything like that, and everything sounds normal. Now we're going to assess the abdomen. The person should now be supine with the bed or table flat. We just be on the couch for now. Arrange the drapes to expose the abdomen from the chest to pubis if they're in a gown. We're going to inspect for contour, symmetry, the skin characteristics, the umbilicus to see if there's any pulsations. His skin is intact. The hair is evenly distributed. There doesn't seem to be any lesions of any sort. Symmetry is fine, and the contour is flat also. We're going to auscultate for bowel sounds, and there's a sequence in which you do this. You want to auscultate first, then percuss, and then palpate not to irritate the bowels. We're going to start in the right lower quadrant. If you don't hear any bowel sounds, there's probably an obstruction and should be reported to the healthcare provider immediately. And usually there are high-pitched sounds. Next, we're going to auscultate for vascular sounds over the aorta, renal arteries, iliac, and femoral arteries. And for the femoral arteries, you kind of have to like get in the groin. Now we're going to percuss all the quadrants. We're going to start in the right lower quadrant. And then you're going to percuss the height of the liver span in the right mid-clavicular line, and the liver is going to be on the right side. Sometimes you have to palpate a little bit deeper for this in order to feel it. Then we're going to percuss the location of the spleen. Sometimes it's usually not palpable, but if you can palpate deep enough and if the patient allows you, it'll feel very spongy, very soft. Then palpate, we're going to use light palpation first, again starting in the right lower quadrant, and then deep palpation in all the quadrants. The light palpation is used to check to see if there's any tenderness, if there's any pain. And then deeper palpations are to kind of feel out the organs and the tissue lying underneath. And to check for rebound tenderness, you're going to press them really hard, really deep, and release really quickly. And if they feel the pain somewhere else, then that means something is wrong. There might be an obstruction of some sort, and you're going to report that also to the healthcare provider. You're going to go in and then come right back up. You feel any pain anywhere else?
No pain.
Okay. And then we're going to palpate for the aortic pulse, which is right in the middle, in the upper abdomen. You're going to kind of take your index finger and your thumb and kind of feel for it. Normally you shouldn't be able to feel one. If you do, that should also be recorded immediately. Now we're going to assess the lower extremities. First we're going to inspect, we're going to check for symmetry, skin characteristics, and hair distribution. As you can see, all of his hairs are evenly distributed. He has a little bit of psoriasis, but there's no open lesions, but you can see a little bit of discoloration. Now we're going to palpate for the pulses. We're going to start with the popliteal, which is behind the knee. I'm going to go under his calf. You can rest, and then feel for it. And you want to do so on the other side as well, but I'm limited because we're on a couch. And then we're going to check for the tibial. And the dorsalis pedis. Then we're going to palpate for just the temperature, and it's pretty cool, it's dry. Or warm to touch, but nothing cool as far as like him losing circulation or anything like that. We're gonna see if you can fan out his toes, separate your toes. You want to check to see, that there's no lesions in between, there's no fungus or anything of that sort. And now we're going to test for range of motion. We're going to do so with the hips, and we're going to ask them to adduct and abduct. And he can do so on the other side as well, but we're just limited because we're on a couch. Now we're going to do the knees, ask him to bring his legs to his chest and then back down. And then same thing on the other side. And to check with the ankles and feet, we're going to do the toes, and you can bring them back and forth in which he can. Assess the musculoskeletal, ask the person to sit up and then dangle their legs off the bed or the table. And if we're in the clinic, you would keep the gown on and drape over the lap. And as they sit up, we're going to note their muscle strength and dangle. We're going to test for the neurologic system. I'm going to test sensation in selected areas on the face, arms, hands, legs, and feet. Superficial pain, light touch, and vibration. So I'm going to ask him to close his eyes, and every time he feels the sensation, he's going to say now.
Now. No. 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 No.
Okay. Now we're going to test for superficial pain, still keeping the eyes closed.
No. 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 No.
Now I'm going to go for light touch. Well, we just did the light touch, and now I'm going to go for vibration.
No. No. No.
Okay. Now we're gonna test the position of the sense of finger in one hand. And then test the stereognosis using a familiar object. I'm gonna close your eyes. Keep your eyes closed. And I'm gonna place an object in your hands and you're gonna tell me what it is.
Looks like my wallet.
Yes. Now we're gonna test the cerebellar function of the upper extremities using the finger to nose test. So keep your eyes closed and span your arms out to the side and with your fingers touch your nose one at a time. Okay, now the other hand. All right. All right, you can relax. Now we're gonna elicit the deep tendon reflexes. We're gonna do the biceps, the triceps, and the brachioradialis. So here we have a reflex hammer, and we're gonna use the pointy end for the for these three. So the brachialis, you want to tell them to go dead weight on your arm. And then you want to feel where the insertion is, and you want to hit that tendon right there with the pointy end. And you will see a little bit of the muscles contract, or the reflex. Okay? And then for the tricep, you're going to fold your hand like this. You're going to go dead weight, and I'm going to hit the insertion. I'm going to hit it hard. We're going to tap the insertion, and you will see this reflex. Okay, and now we're going to do the brachioradialis. I'm going to hold his thumb and suspend it, go dead weight, and I'm going to hit the brachioradialis, which is right here. And you won't see much of a reflex, but it's a really slight one. All right. Now we're going to test the cerebellar function. I'm going to ask him to take his heel and run it across the opposite shin from top to bottom. Okay, now we're going to assess the deep tendon reflexes in the patellar tendon and the Achilles tendon, and we're going to also assess the Babinski reflex, and we're going to come over on this table so he can, so he can assess the patellar reflex. All right, and we're going to look for that. Find the patella. We're going to hit the tendon right there. Okay, do the same thing on the other side. Okay, now we're going to do the Achilles, and note that I've used the bigger side for this. All right, and to do the Babinski, put this leg on this knee. What we're going to do is you're going to take a pointy end, or you can just take the bottom of your reflex hammer, and we're going to start at the heel and go on the outside and kind of do like an upside down J. This is also used in babies when they're first born, and you should see either their toes curl or like fan out. And if they're ticklish, you want to warn them beforehand so they don't like kick you in the face or something. All right, I'm gonna assess in the lower extremities. We're gonna ask the patient to stand up. I'm gonna stand very close to the patient and assess for any varicose veins, which he doesn't have on either leg. Assess the musculoskeletal system. First, we're gonna ask the person to walk across the room in his or her regular walk. Okay, turn. And when you walk back, walk in a heel to toe fashion. Okay, now we're going to walk back, but this time do so on your toes. And then you're going to walk back one more time on your heels. Okay, now we're going to assess for the Romberg test. So come stand here and close your eyes. This is to check his balance to make sure he doesn't sway any more than he's supposed to. A little bit is normal. Okay? Now, if you're in a clinic or if you're in a hospital setting, you would ask them to hold the edge of the bed or the table, but he's gonna hold the edge of this chair right here. I'm gonna ask him to slightly do like a shallow knee bend on each leg. Okay, now I'm gonna stand behind the patient. He's gonna touch his toes and I'm gonna assess his spine. I'm gonna feel that everything is straight, that there's no tenderness, any pain, that there's no lordosis, no scoliosis, or any of that sort either. Okay, stand up. Now we're gonna stabilize the pelvis. I'm gonna test for the range of motion in his spine. I'm gonna ask the patient to hyperextend. Okay, and then rotate. And then move laterally. All right. So originally, you would assess the genitalia, whether it's a male or a female. So for a male genitalia, you would still sit on a stool in front of him and the person stands. First, you would inspect the penis and the scrotum, then palpate the scrotal contents, and if a mass exists, then transilluminate. Check for inguinal hernia and teach testicular self-examination. For the male rectum, for an adult male, ask him to bend over the examination table, supporting the torso with forearms on the table. Assist the bedfast male to a left lateral position with the right leg drawn up. Inspect the perianal area, and with a gloved, lubricated finger, palpate the rectal walls and the prostate gland. Save a stool specimen for an occult blood test. To assist the female genitalia, assist the female back to the examination table and help her assume the lithotomy position. Drape her appropriately. You sit on a stool at the foot of the table for the speculum examination and then stand for the bimanual examination. Inspect the perineal and perianal areas. With the vaginal speculum, inspect the cervix and vaginal walls. Procure specimens. Perform a bimanual examination for the cervix, uterus, and adnexa. Continue the bimanual examination, checking the rectum and rectovaginal walls. Save a stool sample for an occult blood test and provide tissues for the female to wipe the perineal area and help her up to a sitting position. When you're done with the examination, tell the patient and let them know you'll leave the room as they get dressed and will return to discuss the examination, answer any questions, and if need be, then to plan further.